Okay, hello everyone. We're here in Grand Rounds in the UW Arboretum. I think there's going to be more participants joining over the next couple of minutes. My name is Joe Saramelli. I oversee Grand Rounds for the department, and we have a hybrid event happening today where there are some participants here on site in a venue at the Arboretum at the end of a half-day mood symposium. I'll acknowledge Mike Walker and Semhar Braha, who help and work on Grand Rounds each week, and funding for the series through the Garvey Institute for Brain Health Solutions and the Ripley Fund. There won't be an evaluation for today's Grand Rounds presentation, but you can always write to me about any comments or questions about Grand Rounds. This is actually our last Grand Rounds of the academic year, and we'll start the series back up mid to late September in the next academic year. So with that, I'll stop and turn it over to Dr. Unitzer to introduce today's speaker.
Great. Well, thank you, Joe, and thank you for a great year of shepherding our Grand Round series. I think we've had a really great year, almost all hybrid, and today we're doing one of our first efforts to do it mixed. And not with a lot of you still online and some of us here. For this last Grand Round sessions of the year, I have the real pleasure to introduce our speaker for today, Dr. Mark Fry. I'm going to say a few things about Mark and then I'll hand it over to him. Mark's a psychiatrist. He's a professor of psychiatry and he's a recent chair of psychiatry at Mayo, at the Mayo Clinic. He is a real expert in basic clinical and translational research in a whole range of mood disorders, but particularly bipolar disorder. He's also a great clinician with expertise in a whole range of problems: depression, bipolar disorder, and addictions. And he's made some really important contributions to our understanding of all of these topics, working in the area of genomics, brain imaging, the neuroendocrinology of mood disorders, alcoholism, a wide range of really important topics that help us understand what happens to the biology, when we're struggling with bipolar disorder and how we can translate it into treatments. Mark has had research support from the National Institute of Health for a whole host and from a whole host of federal foundation and private funders for his own research. He's won several major awards for his work and published widely. At Mayo, he and his team established a Mayo Clinic individualized medicine biobank for bipolar disorder and created a library of neuroimaging studies in an attempt to identify and understand the underpinning mechanisms of bipolar disorder. He's doing really interesting work in DNA genomics, in proteomics and epigenomics, again, trying to help us understand, subgroups, subtypes of bipolar disorder through really comprehensive phenotyping approaches. And then, again, translating all of these insights into better treatments. So we've had a great symposium here this morning talking about new treatments for mood disorders. And we're going to finish that with Mark's presentation on this topic. In addition to his work at Mayo, Mark is currently the president of the National Network of Depression Centers, a group of major academic medical centers that work together in the area of depression and other mood disorders. And I could spend a lot more time here to talk about all of the amazing stuff that Mark has done in his 30-year career. I know that it's been 30 years because I'll end on something a bit more personal. Mark and I have known each other for a long time. We were both residents together at the same residency class at UCLA, starting in 1990. And I could tell you some really neat things about him from that time. But I'll make it that part very short. Mark's a really great, really nice, really smart guy who is a true clinician scientist, is a model for anybody who wants to think about what would a career look like as a clinician scientist. Still sees patients and has that capacity to go all the way from digging very deep in the biology of what we're becoming to understand better in terms of what happens when you have a manic episode, when you're struggling with bipolar disorder, to how do we turn that into something that helps patients and family members living with this disorder. So on that, Mark, come on up. Thank you so much for joining us today. I really look forward to your presentation.
Thank you, Jürgen. Thank you, Joe. Hello, everybody, and greetings virtually from the Arboretum in Seattle. So I'm really just pleased to be here with this group. This symposium focused on mood disorders today was really invigorating, and I've learned a lot, and I'm hoping that we might see some common ground for areas of collaborating going forward. And that really is the essence of my talk today, as you can see from my slide. I want to talk to you as a clinician, and as Jürgen said, I have found my clinical practice to be exhilarating and exasperating and inspiring all at the same time. I'm a believer that patients really are an incredible source of information and ways to think about practice and clinical innovation. And it's just been a tremendous honor to serve them all these decades. But I want to talk to you about how clinicians and researchers can collaborate today and actually do so, not just at single sites, but the strength that we have when we partner as a network, if you will. So my disclosures are here. And you can review those as you wish. I will be referencing that I'll be talking off-label regarding antidepressants and bipolar depression, and that is the biggest problem that we have, is that there just really aren't meaningful regulatory improvements for the illness. I appreciate the TMS talk in a very similar way. I have had funding from a number of foundations focused on genomics of medicine, or in this case, specifically pharmacogenomics of antidepressant-induced mania. I will be presenting data as part of this presentation, but it is not related to that grant or that specific research question or funding mechanism. I'm going to divide up my talk, and I'm going to move a little quickly on some parts. I had misjudged our time today, but I want to really hit kind of three main areas. I would like to talk to you about the National Network of Depression Centers and what the NNDC is doing from the standpoint of being a national network, interfacing at the federal level and trying to enhance and really push the message to important people in Washington and across this country as to the impact of research at the University of Michigan for a good number of years. John's whole concept was bringing excellent academic centers together as you see here, to really drive the national conversation of mood disorders, thinking that as a network and an integrated group, we would probably be more successful in really having that national conversation than, by all accounts, excellent, really talented individual academic centers. You can see our membership here. We are throughout the country. I transitioned into this role of president last year, and my goal is to really think about the mission of NNDC and how we might strategically our membership. So our mission, as you can see here, is to develop and foster connections among members to use the power of a network to advance scientific discovery, provide stigma-free evidence-based care to patients living with depression and bipolar disorder. You can see who we are, why we exist, and the future that we see is a world free of stigma where everyone has access to effective evidence-based depression care. And we've had some great discussions this morning as to how that is not happening now and trying to think of a roadmap to get there. So John Greedon is our founding chair. Ray DiPaolo is the immediate past chair. I've had the honor to transition into this role about a year ago with just a very energetic executive committee, excited to really think about what we can do as a network. Each year, we have an annual meeting, and that typically is in the fall. And in 2022, that was in Ann Arbor. As I transitioned into this role, I really wanted to better understand each of the sites of the network and basically went on a listening tour with our executive director. And over the course of last summer, met with each chair, the board members from that institution, individuals that were really involved in some of our task groups, and just tried to get a snapshot as to each site, and then really pulling that data together for you to appreciate now. So over the course of our NNDC, we have more than 375 faculty that are funded in any way doing mood-related research. We have 670 faculty throughout the NNDC that identify themselves as having expertise in mood disorders within the specialty clinics of the NNDC. So this would be where I work primarily, a depression center. We have more than 80,000 patients that we see. And if we think about, so where Joe is and integrated behavioral health or psychiatrists in primary care, we estimate there's probably another 280,000 individuals that we touch as part of our work is in psychiatry through the network. We asked all of our members to really identify what are key points of what the network means to them or how they feel the network can move forward. I'm not going to read those key points. You can see it is very much related to the purpose of why actually we're all here today. So let me show you just a smattering of some of the projects that we have. And this is really meant to really give you an idea of just the broad scope of the network and opportunities that might avail themselves collaboratively going forward. Our flagship program, the NNDC, was designed from day one to really create the basis of what we hope will be an active learning health system or learning health network. This was work that has been done in collaboration with the Alterum Institute. We have, as you can see here, created a clinical dashboard where we want clinicians and individuals with mood disorders to be able to see their data and to watch how that data longitudinally can move over time. We want to promote measurement-based health, and we have our vital signs here that we are getting with each of our regular mood outcome program visits. That's the PHQ-9, GAD-7, the Columbia scale. It is clear we need data to better understand the gaps in our practice, and that data can really help facilitate quality improvement projects, both at the clinic level and the population level. So again, that mood outcome program, measurement-based care, tracking anxiety, depression, suicidality. Our patient enrollment numbers have been far higher than we have anticipated, and we are now over 25,000 patients that have been enrolled. We think this is a great kind of base to think about quality improvement projects with multiple sites and multiple patients, or thinking about clinical trials that can be added on top of that baseline infrastructure. Just as an example, we have looked with some of the grants that we're putting in to see how many bipolars, how many unipolars, what's the age distribution of the 25,000 individuals that are in our mood outcomes enrollment. You can obviously see the majority of them have major depressive disorder, their age, their race, their sex. These are the sorts of numbers that we think are very impressive for early studies to think about quality of care or patterns of care over time. To give you an example of some of the work that has been published related to the mood outcomes program, you can see our initial work that was really underscoring how we came to measurement-based care and those specific instruments that I talked about. We're starting to do some mixed model analyses of how those scales relate to each other over time. Do they identify subgroups of individuals, and et cetera. I would say that this mood outcome program took a decade to really get to a critical mass. There are a lot of researchers, clinical scientists that are thinking about next steps with this data set, which we think has enormous potential. Outside of our mood outcomes program, our flagship program, we have developed a number of NNDC task groups. And this, in my opinion, has really proved to be a sweet spot that we had underestimated how successful it would be. We wanted to create an opportunity at our annual meetings and regular workshops for individuals who were like-minded, who had a passion about a particular aspect of mood disorders, whether it be college mental health, biomarkers, neuromodulation, suicide, primary care, telehealth, whatever it might be. We wanted to create an environment where clinicians, researchers, junior faculty, new learners could really have time to talk to each other, think about projects that they all felt were important, and supported those efforts, whether it might be a position paper, a momentum grant, which is $10,000 to $15,000 the NNDC would give to a group to really get a project for preliminary data. These groups that you see here have been hugely successful, and they've organically really just grown based on the people who are part of the network and recognizing they had common interests and common passion and had moved those forward. I want to highlight some of the work that some of these task groups are doing, but I would really want to underscore this proved to be just a gold mine for junior faculty who perhaps had particular interests at their campus, but they didn't have that national leader right down the hallway. They now have access to national leaders and task group chairs that are moving these projects forward at their disposal. It's proven to be a phenomenal way for junior faculty to really meet the national leaders in the field, have chance to work with them, publish with them. It's proven to be really terrific. And I think we also underestimated the value of that when it comes time for academic promotions and assistant and associate professors that are needing to show people outside of their institution that can critically review their work. So let's go over a couple of these. And we'll first start with the biomarker task group, which I've had the pleasure of chairing for the last 4 or 5 years. We're currently looking for my replacement as I've transitioned into a new role. So John Greedon really started this. It's an open trial of ketamine for treatment-resistant depression. And I'll be the first to tell you, this is about 10 years too late. There's nothing novel about the clinical trial per se, other than 6 sites, clinically based. You can see who they are here. The trial design was conventional, 3 infusions, IV ketamine. We chose IV ketamine because the majority of these sites had been working with IV ketamine for 5 or 6 years. They knew what they had with this type of formulation. They had data and ideas that really came together, and we could have a larger sample size to do that. So a typical acute phase trial, 3 infusions, remission rate of 52%, response rate of 67%. Those are conventional data points I'm not going to spend a lot of time on. What will be very unique about this trial is that we have 10 or 11 hypothesis-driven biomarker studies that are now basically going on in parallel at the same time. Let me show you a couple of those. Before I do, let me highlight some other benefits of being part of the NNDC. So many of these research sites had active clinical programs, and we recognized we were getting a lot of questions about how did you actually do that? So about 1.5 years ago, a ketamine work group developed a paper, got it published, and said, here's how you build a ketamine clinic. Here's the footprint that you need to think about. Here's the business plan that you need to think about. Here's what happens when hospital administrators say this versus hospital administrators saying that. This second slide, or the second part of the slide, is really showing you some qualitative reviews from our study. Now, these are people who were in the acute phase, and then we just tracked them 9-10 months later and really asked how they were doing. And what I was really struck by from the group that really was thinking about meaningful outcome measures is some of the qualitative points that you can see right here. We don't often see these types of qualitative outcomes in clinical trials, but when you set up surveys and really have an opportunity to talk to individuals who participated in the study, some of them remitted, not all of them, and really ask them, what's been most impactful about ketamine for you over the last week, over the last year? You can see that we would say quality of life has improved, remission has been maintained, but I don't think we would have caught some of these nuances had we not done this, that someone may not have fully remitted, but they were able to get off their benzos and their Buspar and their polypharmacy had been reduced. For them, that was a meaningful outcome for ketamine. So our qualitative study has already been published. Our clinical trial and biomarkers are moving forward. So here's one example. My mentee at Mayo Clinic is Balwinder Singh. Balwinder had a unique idea for our 3 infusion ketamine to do the first one in an MR spectroscopy scanner, where we were actually measuring peripheral levels of GABA and glutamate and comparing those to central measures measured spectroscopically of the same compounds. What this data is showing you is individuals who, after 1 infusion and had remission the next day, had a GABA increase that was associated with remission, suggesting that maybe there might be a GABA deficit in anterior cingulate that a NMDA antagonist is resolving, and that process is associated with remission next day. We are trying to replicate this in a larger study. We're very eager to really think about ketamine and how that can actively engage a target such as anterior cingulate GABA as one example of the BioK ketamine work that's being done as part of this trial. We have a second biomarker that's at Michigan State, and it's looking at inflammatory markers. And this is the work of Lena Brunden. I'm not showing you the work of our BioK sample because that data is being analyzed as we speak. But this is a great example of looking for scientists who have an expertise in a biomarker that is already assayed and developed, and ask if they'd like to have an incredible rich resource of 73 samples with the 52% remission rate, and each participant has 3 time points of biomarkers. And not surprisingly, the answers have been yes. So knowing how we think about ketamine, NMDA antagonism, synaptic density and plasticity, it's not surprising that the following biomarkers are going forward. So we're looking at GABA and glutamate, both peripheral and central. We're looking at inflammatory markers. Our colleagues have just got their samples looking at brain-derived neurotrophic factor. We have some acylcarnitine metabolites that are being analyzed. Sue Tai, who is a colleague of ours at Mayo, who's gone back to Queensland, has been very interested in looking at mTOR signaling and how that appears to contribute to that synaptic plasticity, and thinking that that might actually be a marker of ketamine response, and looking at that with our clinical trial. I'm showing you here on the left a Mayo Clinic ketamine study. This is not our BioK. Again, it's the preliminary data that we have, where we show a clear remission rate for more than half of the individuals. What I'm showing you on the right part of this slide is their biomarker data showing that responders and non-responders differ by their mTOR activation on top, which is really that marker of synaptic plasticity. And they also differ by their tryptophan metabolites, as you see in the bottom. So our BioK clinical trial, part of NNDC, it is not a unique clinical trial from the standpoint of efficacy, but it will be the only ketamine data set we're aware of that really has multiple biomarkers being studied. You've seen some examples today, and not only looking at that individual biomarker, but how those biomarkers might interact with each other. So I would say from the standpoint of opportunities with NNDC, 25 centers of excellence, an amazing opportunity to really build collaborations nationwide, super opportunity for junior faculty to really get on these task groups and have a chance to connect and really work in a wonderful way with leaders in that area of expertise throughout the country. So let's shift from the NNDC and move more to bipolar specific. And again, I just want to highlight some of the work that we've done at Mayo that is proving to be a source of validation or replication within NNDC, but also as a roadmap for larger bipolar initiatives that are coming to a theater near you very soon. So with my genetics or statistical genetics colleague, Joanna Bernacca, we were lucky enough in 2009 to build a pilot repository for bipolar disorder. Mayo has made it a priority that technology, genomic medicine, AI, anything that is a research tool, we want to have that available for clinicians to really use in the context of a diagnostic assessment or how best to guide treatment. Really thinking of harnessing all this advance in neuroscience and bringing it to the patient and the provider at point of care to really enhance the type of treatment and care we're providing. So we've heard a couple comments today that our treatment strategies for 30 years really haven't changed much. I think that's accurate. So one of our strategies would be, well, let's use technology, advances in medicine, to learn how to use existing treatments with greater precision. Who should go to TMS right away and not have to show 2 failed treatments in order to get an insurance approval? Who should absolutely never see an antidepressant for risk of it not working or flipping into mania? And maybe it's a hard medicine to use in an adolescent patient population, but if there is a biomarker that says this person will do exceedingly well with lithium, maybe we try to really get that started right now, as opposed to 10 years later, where all of our naturalistic data would suggest if you're intervening at 10th episode with lithium, the likelihood of responding is negligible, as opposed to intervening at first or second episode. So with that kind of mission in mind, we've created a bipolar biobank at Mayo with now more than 25,000 individuals who've been gracious enough to partner in research and have allowed a number of samples to be stored, DNA, RNA, serum, plasma, and have allowed rigorous, detailed clinical phenotyping of their illness. This has been a wonderful collaboration with colleagues across the world. Sue McElroy, longstanding colleague through our Stanley Foundation bipolar work some 20 years ago. We've been so fortunate to have postdocs from all over the world. A couple of them have just been so talented and so superb. Stayed at Mayo. They learned how to phenotype the illness the same way we have. And they've gone back to their alma maters and are continuing to collaborate and send samples. And that's Miguel Prieto at the University de los Andes in Santiago, Chile, and Alfredo Cuellar Barbosa in Monterrey, Mexico. So this biobank is disease-related, bipolar. We have recognized the importance of having a control biobank. And so this is something that's not managed by psychiatry, but it's managed at the institutional level of some 50,000 people that have contributed DNA to be part of a case control. So when we are running our analyses, we will have 2,000 individuals with bipolar disorder. We'll ask our community biobank to provide age-matched controls that we know said no to family history or personal history of mental illness, as an example. So here's one of the strategies we had going in right from the very beginning. For those of you who may not know, while bipolar disorder is highly heritable, the risk factors or the risk genes to date really only explain a very small proportion of its heritability. Do I think we're going to have a gene for bipolar disorder? No, we're not going to have 10. We're not going to have 100. We may actually have 1,000. But if we can start to generate disease risk genes and how they might relate to narrower phenotypes of the illness, we're creating more biological power, if you will, to better understand the disease and hopefully design more precise treatments. So as we collected our sample, we kept in mind bipolar disorder is just way too heterogeneous. Ask the clinicians, what are subtypes that they see regularly in their practice that you don't need a psychometric assessment to say it's there? So this is where clinicians said, rapicycling. Comorbid, there's something is very different about a bipolar who struggles with alcohol in comparison to a bipolar who might have schizoaffective illness on multiple antipsychotics and have an elevated BMI. We just ask clinicians to really generate phenotypes that we try to operationalize. Our goal is that these narrower phenotypes and narrower outcomes could actually give us more biological information. Let me give you one example. Over the 10 years we were building this bank, there were public domain data sets that we thought we would start to work with. And one of them is from the GAIN study. And the data that I'm showing you in the upper left corner was our analysis of that data in a very different way. We weren't looking at disease risk genes of bipolar disorder. We were looking at disease risk genes of bipolar disorder as an interaction with BMI, recognizing whether it's the illness or symptom burden or medications that high rates of obesity were very prevalent in our practice. That is a genome-wide significant hit, not for bipolar, nor for BMI. It's the interaction, meaning this TCF7L2 SNP conferred risk to bipolar disorder. That risk was higher as BMI was increased. Public domain data set. We then looked at our biobank. Once it had adequate size, we replicated that finding where you see the minor allele is contributing greater risk in developing bipolar disorder as BMI was increased. For those of you who don't know, TCF7L2 is a disease risk gene for diabetes. So here we have this disease risk TCF7L2 SNP in bipolar disorder, and we wanted to take a look at how those might be different. Duan Liu is a molecular pharmacologist, and his role for all of our work is when we identify a genome-wide significant hit, we ask him to really study the functionality of that. Most SNPs in GWAS studies don't have a functional significance to them. We thought this was very important to take a look at. Long story made short, the TCF7L2 bipolar SNP functions very differently than the TCF7L2 diabetes SNP. And when we developed a pluripotent stem cell astrocytic line, we've identified a knockout or what we call a long non-coding RNA that's highly expressed in CNS, not expressed in liver or pancreas, and really is a model to think about insulin signaling and how that might confer risk with this TCF7L2 gene in bipolar disorder. You might say, why get so stuck on insulin, bipolar? Is that really relevant? Our primary care clinicians would say, yes, it is. Again, data from our biobank, we are looking at easy targets. What are targets that psychiatrists can really track in the context of taking care of patients with bipolar disorder? What I'm showing you here is data from the biobank that shows that our bipolar patients who are in blue, in comparison to age-matched controls matching for cardiovascular risk factors, that they have much higher rates of elevated BMI. Women in particular, much higher rates of central adiposity, higher rates of systolic blood pressure, diastolic blood pressure. These are not fancy biomarkers. These are things that are done in practice on a regular basis, and we can actually track those as part of our bipolar clinical care. Why is that relevant? So this data just got published. To our knowledge, it's the largest data of more than 700 bipolar patients. We're asking them cross-sectionally, what's the quality of your diet? And how does that relate to BMI, central adiposity, current depressive symptom severity, and current disordered eating? So the way to read this slide is, as your diet quality goes down, your BMI goes up, your central adiposity goes up. To our knowledge, this is the first data to suggest as diet quality goes down, and again, this is asking about the week prior to blood draw, depressive symptom burden goes up. People who are more depressed have less nutritious food choices in their diet. As diet quality goes down, disordered eating goes up. Our hypothesis is this is probably a binge-related phenomenon, most likely at nighttime, but we're looking at that a little bit further. So here we have a TCF7L2 diabetes bipolar risk SNP. The bipolar SNP relates to BMI. It functions very differently in astrocytes than the diabetes SNP. We have compelling evidence that we need to be thinking about this space given very high rates of cardiometabolic burden in bipolar disorder and very high rates of depressive symptom severity. So when I see data like this, trying to have a healthier diet just to see if some of this is mitigated makes sense. What that diet might be is far from clear. A lot of interest in just thinking conventionally of low carbs, trying to reduce sugar. Is it a Mediterranean diet? Is it a Mayo diet? Some very interesting ketogenic diet will be presented at the ISBD meeting in Chicago next week. So we'll have to wait and see. But I think the concept of working in primary care in collaboration with our colleagues, tracking these cardiometabolic burdens as to how they might be associated with disease risk and or treatment response, the time to do that is now. Here's one very simple example, a small study, but I think we'll be seeing lots more of this going forward. This is Cindy Kalkin and colleagues' really clever study. Bipolar depressed patients who were insulin resistant. If you had established diabetes, you were excluded. This is a 26-week randomized placebo-controlled trial of metformin. The primary outcome measure is whether mood improved for those individuals who were insulin resistant positive at time of study entry, and with either metformin or placebo, lost that insulin resistance. What the data really shows is those individuals who converted, by that I mean they were insulin resistant positive at baseline and they converted to no longer being insulin resistant. You can see the absolute majority of them are metformin, one on placebo. Losing your insulin resistant positive status was associated with greater reduction in depressive symptoms, and those treatment improvements were maintained over 26 weeks. Metformin is not an antidepressant. This is a great example of focusing on cardiometabolic burden and not paying attention to selective serotonin reuptake inhibition. We might actually find some really interesting targets to really develop further for treatments. Let me give you one other example. So Jürgen had said earlier today, very little treatment advance in this field, and that is correct. You should know that of the 25 FDA-approved antidepressants in this country, none of them, with the exception of fluoxetine, only in combination with olanzapine, is FDA approved for the depressive phase of bipolar disorder. Every single regulatory trial for an antidepressant in this country, if you had a history of mania or hypomania, you were systematically excluded all the time, every single time. And that's why we have this just terrible dilemma where these antidepressants are being used indiscriminately. And you can see that over the course of 20 years, the use of antidepressants is going up. And I will highlight in particular the red line, which is antidepressants without a mood stabilizer. The use of antidepressants is going up. This simply does not align with the clinical evidence base. The clinical evidence base is controversial at best. There probably are some subtypes of bipolars who do very well with antidepressants, but this just struck us as really incomprehensible, and tried to figure out if the bipolar biobank could actually help shed some light on who might do well with an antidepressant, and let's get those treatments to them right away, versus who would do very poorly with antidepressants and try to avoid them. And you heard the example this morning of that mixed presentation, which I think is very common. Individuals presenting, they get on an antidepressant, they're still depressed at follow-up, but now they're agitated, they have insomnia, and they have an energy or a dysphoria that in the room that is palpable. That is actually a mixed induction, and I think we underestimate how common that is, but we can study it. So about 10 years ago, our group was really interested in just trying to say, what are all the clinical factors that are associated with someone with bipolar disorder, depressed, getting on an antidepressant and flipping into a manic episode? Some of these you should find not surprising. If you're not going to use a mood stabilizer, that rate has gone up. There's some fascinating studies at the Karolinska, and we've taken this into some of our risk stratification models. The data would suggest that, yes, there are higher rates of antidepressant-induced mania in bipolar disorder without a mood stabilizer. But if that switch hasn't happened within 3 months, it's unlikely to do so thereafter. So there is this window of vulnerability that we're trying to think, what is that neurobiologically, where that risk is there right away and then fades over time? So if you're just thinking about risk factors, that's one. Mood stabilizer without, or absence of a mood stabilizer, but just for 3 months. Bipolar 1s consistently have higher switch rates than bipolar 2s. They consistently have more anti-manic mood stabilizers on board, and yet these drugs switch to mania for them much more so than bipolar type 2. And you can see the list goes on and on. There's the mixed depression that was being talked about earlier today, comorbid alcoholism, anxiety disorder, age, females. And then there's this genetic signal that has had a lot of attention for a long time, and it's really a genetic variant at the serotonin transporter. I'm going to show you that data. which is really unimpressive. The more important point I'd like to make is if we create a learning health environment, or we have collaborative work where we have just large samples of patients and medication prospective data, we want to generate an actuarial risk stratification. So if someone has bipolar 1, they're not on a mood stabilizer, they have a comorbid alcohol and anxiety condition, they've got a TSH that's below normal, and they have a serotonin short form. For God's sake, don't prescribe an antidepressant. I've just given you like 8 of the risk factors that they have. But if you have a bipolar patient who's on valproate, who does not have an alcohol problem, who is older in age, is long at the serotonin transporter, give it a try. I mean, you have mitigated risk by doing the stratification, and we think that might be a future path to try to use existing medicines with greater precision. So Nicholas Nunez, who's starting his residency at the University of Utah in a matter of days, did a comprehensive review of the serotonin transporter. And yes, the short form of the S allele does have nominal association with antidepressant-induced mania. I find this really boring. It is nominally significant, but we're missing the point. We work with noradrenergic reuptake inhibitors all the time. There are dopamine reuptake inhibitors, and yet we have only focused on serotonin. One would argue that time for candidate gene analysis is long gone, and we should just look at genome-wide association studies. If there's a hit, study the functionality of that in a much more meaningful way. If we want to do pharmacodynamic studies, I would argue these are the designs that we should go forward with. There are lots of platforms that can give you 25 different variants and 40 different drugs, whether they're antidepressants or stimulants, and the clinician and the individual can choose. All of those studies have really failed to find a significant difference of that decision support tool increasing remission rates in comparison to practice as usual. I would argue we will be far more successful in trying to understand genomic medicine and treatment trials if we focus on one drug and we not focus just on PK, how a drug is getting metabolized, or one single dynamic variant, in this case, serotonin transporter, but the interaction between the two. And you can see with one of our studies published a number of years ago, a secondary analysis of a large study of ours, people who failed an SSRI went on to respond to an SNRI. They had a pattern of being an ultra rapid metabolizer at 2D6. That may be why venlafaxine was so helpful. And they were had more serotonin transporter than others. How the drug is metabolized and how it sits in transporter proteins in our brain. Let's think of those together, and not with 20 different drugs, but with one drug and one study question at a time. Couple more minutes. We've been really thinking about ways to study the biology of the illness. What I'm showing you on the left part of the slide is an electron transport chain, complex 1, 2, 3, 4, 5. If you remember, that is how our mitochondria generate energy for every aspect of our life. Ana Andreazza has data showing that complex 1 genetic variants distinguish bipolar patients from controls. Sue Tai, my colleague, has an animal model of mania that implicates complex 4. Hillary Bloomberg has a model that is mitigated by lithium, and that actually is focused on complex 5. One of our postdocs at Mayo was very interested in studying the preclinical properties of all these drugs as it relates to 1, 2, 3, 4, every aspect of the electron transport chain. Let me walk you through an example. So for example, paroxetine, you see all these green squares. That means the preclinical data would suggest that that drug increases mitochondrial energetics by increasing activity at complex 1, 2, 3, 4, etc. That's paroxetine. Here's a sister drug, S-citalopram. There's no green, it's all red. Here are two SSRIs that we put in the same category because they selectively reuptake serotonin. They couldn't look more different in their mitochondrial energetics profile in preclinical surveys. You may know that imipramine is notorious for inducing mania. It's kind of hard to see. That's it right there. So you see 1, 2, 3, 4, 5, 6 green squares. That's the highest number of green squares, but there's one yellow one, which was indeterminate. But there's an example of two SSRIs have completely different mitochondrial energetic profile, and the drug that is notorious for inducing mania, a tricyclic, looks pretty green. So we just took that antidepressant-induced phenotype that we've been studying for a decade, and we asked a very simple question. Is the rate of antidepressant-induced mania higher with antidepressants that increase mitochondrial energetics? That data just got published by Manuel Gardea-Resendez in Molecular Psychiatry. What I'm showing you here is the rate of antidepressant-induced mania with antidepressants that have been shown to increase mitochondrial energetics is almost 25%. The antidepressant-induced mania rate with antidepressants that reduce mitochondrial energetics is 13.5%. This is controlling for as many clinical risk factors as we can, and you can still see a remarkable difference. Do I think this is changing practice today? No. Do I think it's time that we start reconceptualizing how antidepressants work beyond conventional monoaminergic properties that we knew in 1950? Yes. I think time-wise, I'm going to just say that the network has 6 bipolar biobanks, and we have recognized that the rate of enrollment of bipolar patients of African ancestry is unacceptable. And we recognize there is a significant number of confluent factors that may be contributing to low enrollments. And we see as a network a responsibility to try to change that, and have some grants that we're developing this summer to try to increase health literacy, and by doing so, increasing rates of research participation. You should know that bipolar patients of African ancestry who are men have the highest rates of misdiagnosis as schizophrenia. And we think there may actually be a misattribution as to how psychotic symptoms are quantified. Now, at the end of the day, giving an antipsychotic doesn't really make a difference here. But if you've misdiagnosed someone, you've now created a scenario where that patient is significantly less likely to get lithium or lamotrigine. And these really are life-saving drugs that we think, and we show from a number of different data sets, are underrepresented with regards to past history for bipolar patients of African ancestry. Future directions. Over the course of this summer, a very large initiative is going to be released. This is called BD Squared, which stands for discoveries for bipolar discoveries to identify and flourish with bipolar disorder. This mechanism is transformational. It has discovery grants, a genetics platform, a brainomics platform, and we are moving forward with an integrated network. 6 sites have been identified, and we are going to create a learning health network where we have clinical data from the electronic health record, biological data from a repository, everything you'd see in a conventional clinical trial, all getting coordinated and integrated in a data coordinating center, which will be the basis of our learning health network. We want to look at gaps in practice and better understand how we can answer that with a large integrated group. So in conclusion, collaborations are critical to continue the conversation at the local, state, and national level. With these partnerships, you can see a lot of opportunities that while individual sites could do, speaking frankly, probably not to the same scale and not with the efficiency that a collaborative network has, and look forward to hearing more about the wonderful data that I've heard in Seattle today and potential areas of collaboration going forward. I've had just tremendous honor in working with incredibly talented clinicians, scientists, postdoctoral fellows, study coordinators, and want to recognize them here. Thank you very much.
Thank you, Dr. Fry, for your presentation today and walking us through what you're working on in the NNDC. I mean, one thing that stood out to me, and I wonder if you might comment on this a little more, is using existing treatments with greater precision. I mean, I think a lot of us that do primary care work or health services work try to use existing treatments for more people. And this is in a lot of ways a similar mindset, using what we have already and trying to see if you could improve effectiveness.
So I'll answer that in two ways. Number one, I'll answer it by not answering it right away, but you'll see where I'm going with this. So think about that metformin study. We need hypothesis-driven discovery data to design new treatments. I would love to see a TCF7L2 mechanistic treatment get developed really based on data like this that we would test. So truly novel advanced therapeutics really based on science. That's one goal. Second goal is we have a armamentarium of treatments, and they are very helpful for some. How do we actually use electronic health record, biomarkers, the integration of that in a learning health system to figure out for whom does paroxetine work and how do we get that to them right away? For whom is lamotrigine associated with Stevens-Johnson syndrome and bypass that medicine forevermore. So I think the primary care is an ideal place to do this as long as there's data in an electronic health record and ways to really think about that large scale. New treatments based on science and science helping us use existing treatments with greater precision. They're both laudable, and we can do both in parallel, and they'll synergize each other along the way.